So we're going to show the demonstration of a PATZI protocol for this upper jaw. This is an atrophic maxilla. You can see basically one of these cases is now we're treating with the PATZI protocol. And PATZI protocol starts with your pterygoid region implants. Then we typically will place our anterior region implants, and then either a tilted or a Zygoma implant. We're going to demonstrate a Zygoma on this one as well. So first, when I'll start my surgery, I'll go ahead and do a crustal incision across the entire arch. So once I have my crustal incision, I'll place some releases. I'll typically release, my first release will be in the central area here, right at the midline. Then I'll release, usually about, this right here is the malar process, about 5 to 10 millimeters in front of that malar process. I'll place a vertical incision here. Same thing on the other side. So I have a vertical release. What that does is it allows us to reflect our flap and visualize our Zygoma. Okay. And then in the back here, I'll do a little bit of an oblique release around the hamular notch. Then what I'll do is I'll take a little 2x2 gauze, same thing as well, and I'll lay it across the flap and press, and that pressure I'll allow to reflect the flap. So when we're reflecting that flap, usually what we're doing is putting pressure that's helping to stop bleeding, but it also releases that hemidesmosome attachment. Tomorrow we'll demonstrate this with the cadavers. You'll see that it's very, very nice way to get a very relatively quick flap laid. And we use that in conjunction with the hydraulic lift as well of the tissue. So the first area that we typically will place on a full arch like this on an atrophic maxilla is the pterygoid. So typically when we're placing our pterygoid implant, it's a blind placement. So we're using actually our fingers to find the landmark. Typically what I'll do is I'll run my finger on the lingual of the ridge until it drops into the little fossa where that's distal of the tuberosity. And I'm feeling this little area here. What I'm feeling is, with my finger, is this little notch right in here, a hamular notch on both sides. So this hamular notch, the pyramidal process of the pterygoid is around 10 to 15 millimeters north of this. So 10 to 15 millimeters north of this, due north of that, is going to be my aiming point right in here, but it's going to be deeper. It's going to be medial to that. Okay? So how that works clinically is I'll actually take and I will angle the burr slightly medial. Are we getting a good picture of that? Okay. So that way you can kind of see. Okay. Laterally, in this area right here is the maxillary artery. So you want to stay away from this area here because this right here can cause some extensive bleeding. Okay. Also, more superior to that 15 millimeter mark, you're ending up getting into a place where the maxillary artery will enter as well. So that's another anatomic landmark that you don't want to pass. So typically what we're doing in the back here is we're placing usually a 15 to 18 millimeter implant. Sometimes every once in a while, if we have a tuberosity that we have to work with, we can place a longer implant and go through the tuberosity. But the standard pterygoid method is designed to place a 15 to 18 millimeter implant. We'll place tomorrow we'll demonstrate the periotomes are the osteotomes that the SIN kit comes with. So SIN has their own Pterygoid kit, which is the best kit that I've ever used for pterygoids. It's the most predictable kit. Typically, they come in sizes. This is the ones, or the A size, then B. So the A size is A size is 2.6. The B is 3.1. So I would use the A size for a 3.5 millimeter implant, which we don't place a lot of those in the pterygoid region, but 3.8 we will. I'll use the B size for that. Then the C size is 3.35, which we'll place a 4.0 for. And the D size is 3.85. If we need to place a 4.5 implant in that site, we'll place that. We'll use that. Markings on it, usually at 12 millimeters, and then this is the 18 millimeter mark. So similar markings to the long kit drills. Clinically, I find this easier to start my pterygoids with because the bone, typically you can use your finger and actually push it into the area. These models are a lot stronger, so you won't get that same feel, but when you use these tomorrow on the pterygoids, you'll be able to take your finger and actually dig into the spot and you'll feel the hard bone. Once you hit that hard bone, that's your spot where you're gonna start.
Dr. Mike, how do you gauge your start point on that press?
That's a really good question. So there's two particular schools of thought on that. One particular school of thought is you can start at the third molar position. Okay? The other school of thought is to start at the second molar position but the difference is you'll have to angle flatter. Okay? If you're going the second molar position, I have found that to be very difficult sometimes if you have a very pneumatized sinus. It's very hard because you have to go through the pneumatized sinus to engage the other end. So it's very easy to place these things in there and then actually have to go fish something out afterwards. So I would rather, if there's no tuberosity, I would rather start in the third molar region at the center of the crest. So third molar positioning is best, in my opinion. If you have a big tuberosity and you can get the implant to track through the bone, that's when I would go to the second molar position.
Okay.
But you'll find that pterygoids are easier to place in really atrophic maxillas. So I've learned that over the years. Even for some reason that if a patient has been wearing a denture, the pterygoid is a lot easier to hit for some reason. It's kind of funny how it's like that. So I get better stability on those. So this is like third molar region. I'm gonna put my finger in the hamular notch and I'm just aiming for the medial portion of that hamular notch. Hold on, let me unlock my screen here. All right, we'll do that again. So once you go through here, we'll typically angle that and we should be coming out on the medial portion. I'm gonna grab my longer burr here. Long kit. Also, the Pterygoid kit comes with this long drill as well. And it should exit right in this position is where we're aiming for. So if we look in the pterygoid fossa back here, We look in the pterygoid fossa back here. This is where we should be. Okay. And that is our first drill. Move to the second drill here next. Our size implant that we're going to place there is a 14.0 by 4.0 by 18. So we're going to prep this site. Hey G, can you grab me that the Pterygoid kit? It's a blue kit. Never mind, G. I have it. Yeah. So that's a 3.3 drill. This is gonna be our 3.4. We'll plan to place a 4.0. Oh, sorry, it says this is a 3.6. On this particular case, we'll use the 3.6 drill, but in the mouth and in the cadavers, you'll probably only need the third drill, the C drill, which is a 3.0 to place a 4.0. Remember, as long as you drill with the 2.35, your 4.0 should fit to length. I'm gonna grab our 18 millimeter implant. We'll tend to place our pterygoids first, because if we have a good pterygoid, then we can move our access point for our zygoma a little bit forward. I can put it in a second premolar region, which makes that surgery a lot easier. We're using the handle from the Zygoma kit. And here's our pterygoid implant. So we're gonna go ahead and place that. And same thing, as we start to receive torque, we're gonna back off, and then we're gonna insert more. And these pterygoid implants come with a polished collar on them. I will tend to bury that polished collar all the way to the crest. There are some people that elect to leave that polished collar a little bit high. You have the option to do either way. But we have some nice torque here. So that's your implant position there. Once we place our implant there, the tip of the implant is engaging the medial wall of the fossa as a stop point. Sorry, let me rotate it. Okay.
Nice.
Okay. So that's ideal positioning where you want to place that going through that cortical plate. This is the plate that has a lot, it's very, very hard. So it's very cortically dense. Once we do that, I will check the angulation of it so that we can kind of make sure that we have it in the right position. Usually we're placing like 30-degree abutments on these. Which that should be our 30-degree abutment. Be like this nice and parallel. After we've placed our pterygoid implant, then we'll go into our anterior region. Now, what I'll typically do in the anterior is I'll elevate all the way to the floor of the nose. And this little area here, the floor, the nasal floor, I'll place a little sinus curette in that area. and I'll do a lift into the nasal floor. The nasal floor feels a lot like the sinus membrane, however, it's a lot thicker. So you do have a lot, you don't have to worry about perforation as much of that tissue, but I will say it's very vascular. So when I do this, what I'll do is I'll elevate one side, and then I'll take a piece of gauze, 2x2, soak it with green lidocaine, and actually stuff it inside of there, leaving a tag hanging out. What that'll do is it'll help me with visualization in the area. Then I'll go, while I'm waiting for that to kind of clot up, I'll go to the other side, do the elevation on the other side, and same thing, leave that there. So once I've elevated both sides of the floor, the nasal floor, then we'll prepare for our implant placement. We typically will go and place palatally. So our entry point here is going to be palatal to the crest of the bone. You'll see these patients a lot of times have a knife edge crest in this area. So in those cases, I would rather be palatal than any other placement of that implant. The tip of the implant will engage the medial wall, medial nasal wall in this area here. So our trajectory of our implant should go in this direction here. So we'll prep that site next. Yeah, good spot.
Yeah.
Redirect if you're going out the facial. There we are. We're through the nasal floor. I'll move to my long kit here. And now we'll continue to prep all the way through the nasal floor. So now this, if I had a 24 millimeter implant, I could engage this medial portion of the nasal space here. Nasolacrimal duct is a vital structure that we need to watch out for. It's typically about 20 millimeters north of the nasal floor. So typically we don't want to go too long with these implants. If that happens, the patient will complain to you about watery eyes. They just won't drain. Treatment for that, remove the implant, curettage the area, make sure that there is drainage. So we'll go and prep with our second burr here, same spot. And then we're going to go up to our third burr. And here in our kit here we have 18. Oh, we do have a 3.8 by 20. Put a 20 in there. And you're passing through 2 cortical plates. So one at the crustal bone and one at the floor, the nasal floor. If you really desire an extra for stability purposes, if you desire an extra cortical plate, you can go through that medial nasal wall there. Most times on these cases, if you have about 5 millimeters of native bone, you'll get something that torques out usually by going through that cortex and just resting on. So typically what I'll do, if we're not gonna, if I had a 24 millimeter implant, I would place that and engage this medial nasal wall. But for purposes of demonstration here, what I'll do is I'll usually sink that subcrustal, usually about 1.5 to 2 millimeters. And then we'll graft this area. We'll place bone graft in this area. So typically I'll graft this area, put a little membrane over the outside or the inside of it, and then close the patient up. So that's your transnasal or nasal cortical implant. Next, we'll move into the positioning for the Zygoma implants. Zygoma implants are nice. The extra we're using what's called the extraoral approach for extramaxillary approach for zygomatic implants. This is a lot easier than the traditional approaches because this one you can actually see the implant the entire time. You can see the drill placement the entire time. So this is a non-blind placement of an implant. Because of that, it's become quite a bit safer for the process. So I'm going to take some time to kind of show you our landmarks that we work with these. The first landmark that we're looking to identify is the malar process right here. And this is the part that connects from the alveolus to the zygoma. So it's basically the bump. So that's our malar process. And then we have the zygoma bone here, which is the zygomatic arch. Where the two meet usually is our aiming point for our implant. So the way I do it clinically is I'll draw a line from the malar process and then draw on the zygoma, and I'll have that intersection point where the X is, and I'll usually go slightly lingual to that X. That's how I identify my positioning of my zygoma. So usually when I'm placing this, what I'll do is I'll reflect the flap with my fingers, and then there on the zygoma, when you get to the zygomatic region, there are insertion points for the masseter. The masseter muscle lies and it attaches to the inside of the zygomatic bone. You don't want to cut that muscle, because if you use a sharp tool around it or pierce it with the drill, you can end up with a lot of bleeding in the area. That's very difficult to control and is very difficult to see after that. So the technique that we use for dealing with the masseter muscle is I actually will take my thumb and I'll take a piece of gauze and I'll peel off a few fibers of that masseter enough so for me to visualize this joint between the malar process and the zygoma bone. You can take a very sharp molt and you can disconnect it from the bone as well. My best recommendation is to use the blunt end of the molt. That way you don't pierce that zygoma or pierce the masseter and start bleeding. So typically when I'm getting ready to place these, what I'll do is I'll aim for that spot, and my best recommendation, if I turn it this way, would be okay. My best recommendation on these ones is I'll go in at first and I'll just make a very small, I'll tap my handpiece and it will actually drop in to the sinus. So I'm basically making a purchase point. You'll feel it drop. Once you feel it drop, stop. From that position, then we can use our safety burr. This is a barrel diamond, it's a safety burr. Basically, it's designed to cut laterally. The way we use this is we place it inside of that osteotomy and we'll lean it up against the bone and use that, tilt it up against the bone and continually cut.
The Zygoma kit?
Yes, this is a special burr that's inside of that Zygoma kit. And we can, the nice thing about this burr is that it won't cut the Schneiderian membrane. So the key with that is that you're able to cut the bone without having to introduce like extra trauma and lots of water into the sinus. So airway control is always a big concern. Sometimes I'll take a little sinus curette and I'll just kind of like release the Schneiderian membrane inside of there just so that we have a little bit of like cushion for that membrane to kind of push away. Key points on this one is when you're doing this barrel diamond, you want to actually lean it in so that the number one thing I see most new dentists starting this process is that they don't create as much of a notch as they should. So if I show you in a different angle here how deep this is, you want that barrel diamond into the crest, the alveolar crest. You want it buried into the crest because the vital structures that are medial to this are, you're going to get into the orbit, you can get into potentially, so I would rather you be lateral, and the way to go lateral is to bury that. So once you've created your little notch there, now you have a little channel to use as your guide. That little channel, you'll start with your burr kit here, and the key is you rest it right inside that channel, and then you can go ahead and enter the zygoma. And the key with this one is you want to make sure that you're coming out the other end because you want bicortical fixation with these implants. So you're getting one cortex at the base of the zygoma and one cortex at the tip of the zygoma. That's our first drill. We move to the second drill here. I actually like the size of these drills that SIN has. The size of the drills is actually a little bit better than some of the other Zygo kits out there. I find we were using the Blue Sky Bio one prior to this, and the Blue Sky Bio has, the drills are a little too long. These ones are a little easier. So second burr, we're going right through that zygoma. If I hold it this way, you should be able to see that tip coming right out of the area there. Okay. Okay. We're gonna go for our third burr. After the second burr, we'll measure. So typically once I'm through, I like to take a little bit of measurement, and there's a little hook on the end of this that goes through the zygoma, and you can pull back on it and take a measurement. So I'm measuring to the center of the ridge with this, and this one is 35 to the center of the ridge. So it looks like we're going to be placing a 35 millimeter implant. We'll do one more prep here. With the last drill. Okay. Now that we've got that prepped, we'll go ahead and grab our zygomatic implants here. We've got in our kit here, you've got a 37 that will work. These come in a little vial. You open the vial like that, then place your driver on the implant. Then we'll insert the zygomatic implant through the osteotomy, and a lot of times what I'll do is I'll take my finger, and on the polished end of it, I'll hold it into the alveolar ridge, and that will help me get the implant started. Once I have the implant started, it's the same as those other high torque implants. We'll advance and pull back, advance, pull back, advance, pull back, and continue that cycle until you're all the way seated. And I like to have engagement on the tip of the implant. That to me is ideal, having the tip of the implant right here. The nice thing about the SIN zygoma is it's rounded at the end. Some of the other zygomas on the market have a very sharp end that can cut into the tissue and be very annoying for the patient. If you overextend your implant placement, then what we do is we amputate the end of it off. So you just take a high-speed burr with carbide, and you just actually will take the tip of the implant off. So complication-wise, you don't want to have too much of this hanging out, but you do want the tip engaging the cortical bone just to get that anchorage.
So where you made the notch in the side of the maxilla, will anything fill back in there?
I'll usually place bone graft.
Does it take pretty well? I mean, you may not even know. You probably just cover it.
Usually, yeah. Well, actually, believe it or not, I like Ogma. What I'll do is I'll cover this whole implant with Ogma. I'll put the Ogma in there and just pull the Ogma out, and it'll just cover the whole area. The other thing that a lot of doctors will do in this case is they'll take the buccal fat pad from I'll show you tomorrow.
The buccal bat pad?
Buccal bat pad. You take the buccal fat pad and you suture through it, and then you can pull it over and suture it to the palatal tissue, and that will cover that area so you don't get a dehiscence of the tissue. Yeah. So I'll show you that. That's actually a really fun thing to do on the cadavers because we can actually demonstrate that pretty nicely. So, and there's a technique to grabbing that little buccal fat pad. I take a little surgical HVE tip, and I'll go and I'll or a yank hour, and I'll go and I'll suction in this area right here. I'll put it in there, and you'll see the fat pad come out. Not every patient has them, so some patients that are very frail and a very skinny face, they don't typically have them, but by and large, about 50% of the cases I'll do a buccal fat pad advancement.
What angle multi-unit do you find yourself using?
45s, 52s, and 60s. It is very, very common for us to use 60s now because for some reason, and it's kind of funny to see how the patients are. I've gotten to the point where I can kind of tell by looking at their face. If their facial third is very flat facial third in the maxilla, and they have a wide upper jaw, I know that I'm probably going to end up with a 60 on those. But this case, let's see how a 45 looks. So that's rotated too much, so I'm going to take that out. This is a little bit of a long implant. I would probably want a 60 on this. See how that's coming out? So I would estimate that there's hey, we have a 60 back there. Could you grab one?
Sure.
See how that looks. By the way, they just put the new holders on the multi-units. Have you seen those yet?
Shorter ones?
Yeah, they're nice. I like them. That was a little surprise.
Are these them right now?
No, but I think we got one. I'll show you.
They're not as tight on there. The other ones, sometimes you had to
yeah,
you couldn't get it.
It was hard to get them off. Yeah, now the assistants can easily take them off for us. Thanks. That's a 60, right?
Yeah.
Cool. So that's another cool thing about the SIN system is we have the ability to place 60, the 60. That's perfect. So that's awesome because a lot of the systems don't provide that. So and the one system out there that does have it is this part here is longer, so it actually sticks up above the gum tissue a little bit more. So that's what I like about the prosthetics for the SIN implant is that they're a little bit more low profile. If we were to put all of our other multi-units in place here, I'll show you what that looks like. We're aiming for parallelism, which this is pretty close. I'll take it. We can get usually a nice passive fit that way. May put a 17 on this front one just to get a little bit better angle, and maybe a 45 on this one. But by and large, this will fly. Now with the new screws that we have and all that stuff, we're able to mill direct to multi. This is the way to go. You'll also find that when you're only offering the fixed option, you're gonna get so much more efficient at using this stuff that really it doesn't even make sense to stock locators anymore. So Cool. Any questions?
That's crazy.
It's fun. This to me is what makes me, I like to get up in the morning because it excites me when I'm able to offer this to patients. Pretty cool. So
Yeah, it's pretty neat.
it's an excitement factor.
Do you see that being an option a lot when they are like a really narrow ridge, big sinuses, or what's kind of the patient selection where a zygo is going to be?
Great question. Not every patient has zygos to use. So we do have to take a CBCT scan, and what I do is I'll typically measure this distance on the CBCT. I'll take the measuring tool and I'll measure from here up to the orbit. And if that distance is less than 12 millimeters, that's a red flag case. So that tells me, hey, we don't have enough bone. We can't do zygos. So that's my kind of tool that I'll do. I'll take a cross section and I'll just kind of like measure that. So 12 millimeters is my cutoff. So because I know I can't bail myself out with a second position if I need to. If the first position I didn't get the right anchorage over here, I can't go north and then hit it there. So that's ideally my bailout position if I need to.
You said 12 millimeters?
12 millimeters. So, and then a width of, then I'll take another measurement, a width of 5 millimeters, this distance. So the buccal lingual distance of the zygoma, 5 millimeters, 12 by 5. That's my minimum. Large sinus, we've made them work out as long as they have zygomas. I'm okay if they have a hefty, you'll see a phenotype of patient. It's the weirdest thing. And I don't know where it comes from, like maybe ethnically it's related, but I see it's almost like a huge wide zygoma. It's, they term it like a Zaga classification 1, but basically the really wide zygoma, but nothing on the ridge. Like the ridge is just super resorbed. I don't mind placing on those ones. I think we can get good anchorage with the extramaxillary technique.
I guess that last sentence, you said, do you think you can get
good anchorage, good torque value with the extramaxillary technique? Because these are actually, it's kind of like, so how this all came to be is we were doing zygomatic cases where we were doing quad zygomatic cases for like a style of maxilla like this. And the challenge that we had with it is you're putting this really long implant with an anchorage point at one end. So what would happen is we called it a springboard effect, almost like a diving board, where it's connected at one end and the other end actually like will move. So the patients will come in and they'll be like, it feels like it's moving. Like, and it's not it is moving actually because they're anchored at one point. So that's the reason why we started placing these anterior ones into this area, because you're not getting that springboard effect by having that more vertically placed implant. You've got to stop there. So.
What kind of torque do you see with those zygos?
60 plus, rock and roll. These zygos are rock and roll. These are rock solid zygos. Every time I place one, I think I had one case where the lady had like, I told her ahead of time, I was like, yeah, this is kind of a long shot, but we're gonna graft you if it doesn't work. And we were able to get on her was like 45, but normally it's to the point where I'm cranking on it and backing it out, cranking on it, backing it out, cranking it just to seat it. So the zygos to me are like, it's game changer as far as stability wise. I think it gives me a lot of confidence to be able to provide that to a patient as a kind of like back of my mind idea. When I first started doing zygos, I saw them as a bailout option, as in case we had a patient where we had something that failed or grafts that failed, we would use them. Now it's become more of a first option for me on a lot of, probably most of my cases. I would say probably about 30%, 30 to 40% of the cases that we do are zygo cases now on the Maxilla.
Try to do a pterygoid in most cases?
Yes. I would love to have a nice pterygoid on those cases because of the fact that that springboard effect that I was talking about, it mitigates that and it mitigates a cantilever. So those are the two things that we make it so that it's a lot nicer. We don't have to deal with that cantilever in the back. On a case like this, let's say we weren't able to hit our pterygoid, what I would probably do is I would lateralize this anterior one a little bit more and make it, instead of a transnasal, I would make it a piriform implant. So I would go here, I'd place one there, and then I'd go for a center point implant right here, a Z-point implant. This is called the Z-point right here. So I'd place the implant right in the center of the ridge and do a piriform here, which is the same as a transnasal, only it's blind placement in this position. And then I'd have one here. So I'd have 3 in the anterior region.
Yeah, and it's more predictable, so predictable. Zygo, I remember I was talking about with the doctors 20 years ago when I was in this Zygo. It's the design of the implants changed a lot.
I was surprised. The first time I felt it go in, I was like, whoa, this is solid. Like, it's weird the way that it tracks, the way that, and also the nice thing about the Zygos, and we'll see this tomorrow in the demonstration on the cadavers, it's visual. You can actually see the Zygo. So I'm looking for the tip of this. Everything is done. It's not blind. The pterygoid position is a blind placement. So it is harder to kind of get those reps and feel confident with the pterygoid. It's not always a slam dunk on those.
It's I think nowadays it's a great option because we have a lot of papers and research and failures in sinus augmentation. It's a big sinus as a 4 classification. They try to put PMP, a lot of, and the research showing a lot of failures, and frustration for the doctor, frustration for the patient, and they did some research and say, these patients, the options in the past, the option is sinus augmentation, different.
Yeah, not everybody can be grafted.
Yeah, exactly.
Yeah, not everybody can be grafted, especially those osteoporotic patients. So it's nice to have this in your back pocket going down those roads. So
here's a quirky question. The Zygo implant, what would happen if it was coated?
It is coated.
Is it? It integrates around that?
Yeah. So it's HA. All the Zygos now, from my understanding, are HA coated. Is that right?
Yeah.
Okay. So yeah. So everything, all the Zygos that they have are HA coated. Okay. Not like the regular implants where you can order one that's HA and one that's not. The Zygos all are HA coated.
Okay. Well, I wondered because it's so smooth, but I thought
polished collar, you're not going to get bone integration usually. Yeah. So you won't get bone integration, but you will get.
That's fine. I mean, if you had the old school Zygos had threads all the way up.
All the way up to the top.
Exactly.
And that's where you'd get infection.
Yes.
You're getting your stability in that Zygo bone. So
I understand that part, but I just thought if you got integration at the top 2, you'd have 2-point.
A cortex.
Stability. Yeah.
That plays for the old school idea, but the problem that we had with that is like he said, those infections.
Okay.
And when these things get infected,
that's just something I've wondered.
Not a good day.
Implant. Yeah. That makes sense though.
Yeah.
Okay.
It's like I can't say impossible, but retrieve a Zygo.
Oh yeah.
Not fun. Fracture of the Zygoma. Yeah, because you have to think. They're torqued in there.
That's true.
And then they integrate afterwards, you know? So that's a part of it.
Leaving that little piece of hardware in there.
A lot of people will, if that happens, if you experience those, you amputate the implant, basically. Yeah. Yeah.
Okay, just a question.
Rock and roll.
Sure.
It's a good question.
That's the place to
These are important questions to ask because of the fact that complications, treatment of complications, flushing all that stuff out as best as possible is really important.
Yeah, for sure.
So if you guys want to do some model work on the zygomas and maxilla, let's go through that too. I'll be happy to help you with this. Awesome.
I don't know what I know. Pablo is doing some zygos, but he's not a big fan of zygos. I know, but he went for my friend's course over there. But I don't know, in Utah we have, but it's good to have.
I've noticed it seems to be catching on. I know one of the guys I know in Colorado that got into this and has been doing it for a while.
And in Colorado Institute, Implant Institute, I think the guy's doing it, I think so.
He's done all through CE courses and stuff, but he's been doing all on fours for a while. And he's going to Zygos because he's seen some failures with just the traditional, implants.
Yeah.
So he's like starting to do more Zygos too.
Sure, yeah. It's more predictable long term.
Yeah, that's what he said.
Yeah, sometimes it's better.
And he's spending a lot of time, I guess. He's
redoing some cases, and sometimes
he treats a lot of the tissue problems, like soft tissue problems that you get with those cases too.
And zygos you will have dehistance as well with the tissues, so that's another part of it.
Even just the normal all-on-fours. He spends a lot of time fixing other doctors' tissue problems that they don't know how to treat.
Soft tissue maintenance is huge.
Yeah.
We want to have some nice tissue. So that's the other part of it. Like long term, when we get done with these cases, we maintain them too.
Right.
So like there are companies out there that they don't maintain their patients. They do the work and then they say now you have to find a.
What he's doing because there's nobody there that does it in that Colorado. He's the only guy.
no maintenance there. It's so weird because you do the case and don't maintain the case. It's like, I sell this product for you, but bye.
They paid a lot of money.
And say bye.
Does nobody do that?
Yeah.
That's the challenge here, but that's good for us. I mean, we get patients all the time from them. So,
how about Clear Choice?
Clear Choice is not anymore. They're moving to that model, that same model. So, I like Clear Choice's model a lot for a long time, but I think they're just kind of, from what my understanding is that they're moving towards more of a one-time fix model. Everybody's moving into that. Let's see what we can get you to zirconia as fast as possible. Nuvia is like 24 hours. Clear Choice is introducing their teeth in a week, so that's the next step on there.
To the final zirconia.
Yeah.
I'm surprised.
That could be the new fad. Everyone's just going to race to the...
Everybody's going to race to zirconia.
Yeah.
That's what's going to happen. Over the next year or two, you're going to see that. And then, let me tell you, so there is a benefit to it. The nice benefit is you don't have to, when you have a busy practice, like our practice, where we're doing last month was what, how many arches? It was 50?
52.
52 arches. So think about 52 people in temporaries every month. Now combine that over the course of four months. So what? That's, you're getting into hundreds of possible fractures every day that you walk in. Could be 100 fractures that happen on a bad day, and we that's why we're going to zirconia fast, because we don't want to deal with the chair time of reprints for that many patients that we're putting into zirconias. So that's the challenge.
Yeah, and this kind of reprintings, it's trusting because the patient starting don't trust in that kind of treatment.
Yeah.
They say, why?
They're not educated
Cracking,
enough.
Cracking,
Yeah.
cracking,
Yeah,
and
even
then-
if you tell them, they don't remember when it breaks. They don't remember
Exactly.
Yeah,
Never,
exactly.
never, never.
that. You probably did tell them, and still.
Do you use
they're
that tough
"We're
tube?
wrong."
That-
Yeah, Onyx Tough too.
Tough too, yeah. I mean, that's FDA cleared for final.
Yeah,
Yeah, but sometimes crack.
yeah, that's the problem.
Because the patient, they don't understand. They say, oh no, I can't eat them. No, you can't. You can't. But they go.
They're chewing on ice. They're chewing on. You're like, well, I should be able to eat ice. Well, okay.
So normally you would have them in the temporary for how long?
Normally 3-4 months.
Okay.
Yeah, 3-4 months. I would say 4 months is the common thing. 4 months, and then after that, bring them in, take another tissue scan, go for that. Having the photogrammetry on board is key. If you have photogrammetry, and the micro mapper is something that SAN offers, is one of the best photogrammetry units, in my opinion, probably the best one. It's easiest to use and very accurate. I would say that you're probably like, as long as you can get that photogrammetry in, you can go to zirconia pretty rapidly. There's a cutoff of arches per month that I would say that it really makes sense. So if you're doing like 4 of these cases a month, I know they say 8, don't they? 8 or something like that.
For the photogrammetry?
Yeah,
I
yeah.
think it's like 3,
3, yeah.
which will offset your...
that offsets your
fees.
cost.
Yeah.
Yeah. So at
You
that
talk
point,
to some docs and they're like, I just need 1 because my time is worth way more than
Yeah.
that, and the time that it takes me to take,
yeah,
you know, the pickup and the
Yeah.
impression and doing all that.
it's a lot of work to do that. Like
don't have a lot of
sectioning the jig, and it's just, we used to do it, and it's like, I can't imagine myself doing it now just because of the time factor that it takes to do it. It's a
For the
lot of
patient,
work.
It's a lot better experience.
Yeah. Yeah, and also, like, you think about it, even if you are using like a CRNA or something like that, you're paying for that time in anesthesia. So you really can look at, from the long standpoint, is, you know, you're saving some money on the anesthesia, but then also the nice thing is you're not putting that patient through like more sedation than they necessarily need.